Got it. Yep.
Okay.
We're live.
All right.
All right, very good.
Yep.
Good topic today.
Yep. A nice summary.
Yep, a nice summary.
Yes, sorry,
Isn't it
that's
cute?
Yeah.
Spondyloarthritis. So let's go to the learning objectives. So you should understand when to suspect spondyloarthritis. It's a bit of a difficult diagnosis. You should know how to recognize dactylitis on physical exam.
Okay.
And you should know what imaging tests are helpful because, again, to me, our role is diagnosing this.
Mm-hmm.
And I would say it's a role we miss sometimes. So,
Clearly.
okay.
The spondyloarthropathies.
Say that faster.
Yeah.
I
Exactly.
have trouble with this word.
I think it was a good topic, and I learned some interesting things from this that I think sometimes you read a fact and you think, well, it sounds outlandish, but in this case, I think it's probably true. How long do you folks think that the person with the spondyloarthropathy will go before they're properly diagnosed?
From the time they start seeing a doctor for their complaints to the time the doctor figures it out is what we're saying.
Yeah.
5 to 10 years.
8.5
That's pretty
years.
close. 8.5
Yeah.
years. And that's the average around the country.
Yeah.
You know, so the part of the problem is, of course, a big part of its presentation is axial low back pain. And low back pain is so much more commonly
Mm-hmm.
something that we kind of treat, and there's no neurologic factors, and imaging usually is not helpful. And so on X-ray or MRI, what would you be looking for when you were trying to diagnose it?
Sacroiliac.
Yeah, inflammation in the sacroiliacs, which doesn't show on plain X-ray very often. And if you get an MRI of the lumbar spine, it's not going to show either. They're not even looking at the sacroiliac. And you actually have to tell your radiologist you're looking for spondyloarthritis in the spine so that they can do special weighted, I forget the word for it.
T2?
I don't know. They like to make that stuff up. But special weighted images on the MRI. So I see people, I think another reason we miss diagnosis is like, that might be it, but let's go look at the x-rays, they look okay, MRI doesn't show anything, and that's because it's all been kind of routine.
It also responds to NSAIDs.
Yeah,
And so we
quickly.
And it's young people who you're going to give an NSAID to. So I think if you take nothing away from this other than you need to have a high index of suspicion, that's really the thing to take away. The other thing is that I learned was, for some reason, and I don't know what other people think, I had always had angst as being a disease mostly of men.
Yeah.
And that is not true. It actually affects men and women equally. So,
and that probably again goes to diagnosis bias, I think.
yeah, for sure, because clearly if you sort of have the average profile in your mind, you can get misdirected away from what is in fact there.
Right.
And of course I think the diagnosis is hard, and having a high index of suspicion is important because there's not one single test you can do.
I agree.
And
I think too, we've always thought, there's not much you can do. Or in some of the spondyloarthritises, we've had a misperception for years. I was taught this, that it's not inflammatory, that you don't have to treat. But there's a lot of extra-articular manifestations, especially like in angst, right, that you want to be on the look for. So, structural heart disease, conduction problems, all those things are all part.
Yep. Even cardiovascular disease.
Right.
Just heart attack risk.
Right, and there's treatment now
Mm-hmm. Much
to
better
prevent
treatments.
that.
Yeah.
No, you don't end up looking like this with angst,
Yeah.
which was all we could do. So, no, it's very, very good. Besides angst, there's like psoriatic arthritis, which again, the article pointed out, which I find kind of sad, is that even if you know a patient has psoriasis, people are often missing the diagnosis. And those people should really kind of get a special focus on that. So.
Yeah, and you can have psoriatic arthritis without
Any skin
findings. So again, high index of suspicion. And I think the article kind of hit on that several times. And should we talk about, one of the things they suggested was kind of what I would paraphrase as a low threshold for referral.
Yeah.
And I think, do we have a slide on it, or is it just
it's towards the end. First I'll show you physical exam finding, which I also think You know, when you go through like Google Images, you'll see somebody with all 5 digits with dactylitis. I don't think that's typical.
It's
And
usually one.
It's usually one, and sometimes the patient tells you it's always been that way. I must have broke it when I was a kid. You know, all those kinds of things. Do people know what's going on with dactylitis? What is dactylitis?
Puffy,
Yeah.
large, and sold.
Sausage fingers.
Sausage.
Yep, sausage fingers. And it's inflammation of the whole digit, the joints,
Yes.
the tendons, the insertions of the tendons, all of that. And so it's like way different than like in rheumatoid
Yeah.
inflammation. So-
Exactly. So how do people with rheumatoid show up?
Puffy joints.
Well, they have particular
Yeah,
joints.
they have like
And it also tends to be
MPP
symmetric,
and-
right? Not only in that particular
Yeah,
hand,
through
but
the whole
across
hand.
the other hand, it's usually similar. What about lupus? Lupus is also a disease of young people. They get encephalopathies. If I
Yeah.
said that correctly. Don't ask me to spell it.
I'm not going to correct you.
What the heck is an encephalopathy? I don't know. I can't even say it. So the lupus.
It's those
people-
insertions again.
Yeah, it's so the lupus people, their hands get deformed over time, but it's because they get an inflammation of the tendon and the joint becomes loose, so they don't actually have joint involvement.
Yeah.
Theirs is tendon involvement
Right.
versus like the psoriatic arthritis or somebody with the reactive arthritis. They have these asymmetric, the whole fingers, like one finger's involved,
Yeah.
that kind of thing. So that helps you with the differential.
Yeah, and this is another important point of why we should not be overlooking this. This again is a severe disease, and people, there's a big burden of suffering. So this is, I thought, was a really nice thing about diagnosis. And so I think the key thing is if you got somebody with low back pain younger than 45, and especially if they're less than 35, and then they respond quickly, usually within 2 days, to non-steroidals, those are people you ought to start looking for different things. And it's not a given that they will have HLA-B27 positivity, but you should do that because that's actually one of the diagnostic criteria. So the article that we use, the NICE guidelines for, in this, what does NICE stand for? I don't know. Okay, I shouldn't have
I got
asked
it
him.
here.
I thought he knew.
I didn't. It's a
Stop,
summary
Dr.
of the
Burke.
NICE guidelines.
Yeah, exactly. Stump Dr. Burt. But so if they have an HLA-B27 test that's positive, they need 3 criteria, and that is low back pain starting before the age of they were 35, the dactylitis, a history of current or past arthritis, and that arthritis can be very migratory in nature. It often doesn't just sit in one specific joint, and so they can tell you kind of a wandering. Waking in the night, during the night, because of the symptoms is another thing. A first degree relative, psoriasis, improvement with movement, buttock pain. So all of those means everybody that you have suspicion with that should see a rheumatologist at least once. And again, because there's a lot of extra-articular manifestations and there's good treatment to prevent really severe deforming disease and stuff like ink-spawn that they should see. So I think this is a nice chart, and hopefully it'll make it up on the blog because it's
Yeah.
a nice thing to have in your phone or something to look at. And I have to admit, I probably have missed it myself because people don't present strikingly.
Yeah.
So, I mean, just kind of, if you could put in your head, if I see a young man or woman with low back pain, and it's fairly chronic in nature or recurring, maybe I should be looking at some of these other things. So.
Or if they have intermittently swollen digit
Yeah.
or something unusual.
Yeah.
And I think even with the reactive arthritis, you usually have to dig for a history of,
Yeah.
I had a GI or GU infection, those
Yeah.
kind of things.
Yep, so talk about reactive arthritis a little bit. I don't think we brought that up, that
Right.
this can follow like STDs and
Yeah.
diarrhea and all those kinds of things. So.
But it's usually not
But
obvious.
people don't remember it.
Yeah.
The timeline, I think, isn't
Mhm.
like, oh, I had it, and the next day I got diagnosed with whatever, Yersinia or something, and then the next day I had the arthritis. It seems to be an ongoing type of antibody type of thing. So.
And I think one of the things that we get hung up in primary care is that we start looking up, even if you suspect it, you look at the criteria and you're like, well, they don't meet all the criteria. Maybe I shouldn't refer them to a rheumatologist. I think what I always think about is like the 11 criteria for lupus. You have to have so many, but that's
Yeah.
for research.
Right.
right? So if you wait till you get all the criteria, the train has probably left the station. And
They may
so-
have permanent deformity by then.
Yeah, and hopefully the rheumatologist can help you and start treatments
Right.
early.
Right.
Should we talk about basic treatments?
Yeah, I
They're
think so.
Kind of the same, right? So if you guys had an ankle spawn, what would you want to do for treatment? And this also, I think, comes back to us for monitoring.
Yeah.
We would hope.
Steroids.
Oh,
Right to the.
there we go, right to the punch, yeah.
Yep. Definitely DMARDs. That's a great advancement that
Mhm.
I have seen in Ankspon, because really I have seen a lot of deformity, and it's a sad disease to have. And like I said, there's heart disease, all of those things that go with it. So
Yeah,
NSAIDs, DMARDs.
and the DMARDs might even just be like a methotrexate,
Yeah.
which I think psoriatic arthritis is probably the preferred agent,
Right.
but you can step up, they'll sometimes step up to a TNF alpha inhibitor.
Yeah.
They also have the IL-17.
Yes.
Yeah.
And I think
as well.
our job is to also sort of, when we see that person back and they're on these things, is to monitor for toxicities. And so, what about the TNF alpha inhibitors do you guys need to know? I heard TV.
TV.
Okay, that's great, but what do we...
Wait, I think the
what's-
camera heard you before
Yeah.
the residents did, but okay.
What do you see in the Midwest, though? We don't... I've seen it a couple
Histo.
times. Histo, yeah, good,
It
yeah.
flares up.
It does flare. I think
Yeah.
somebody, I think it was the Monday, was it you? So it was, you had the guy, somebody had a guy that died of histo here recently in the ICU. They were telling me it came in with high fevers and disseminated. So it really think about it here.
Yeah, yeah, and I don't think it's clear yet. I haven't seen any articles on it, whether DMARDs actually modify some of the extra-articular things. So again, back to Ankspon, make sure you're doing EKGs, echoes, those kinds of things. They haven't been out long enough to see whether that prevents progression. I think the hope is that it is.
Yeah. I think if they're getting steroids too, keep an eye on looking through the chart and getting them set up with a DEXA is something
Yeah.
we should make sure doesn't slip through. And,
Yeah,
and then good physical therapy, aquatic therapy, and those kind of things. But I think that's
yeah,
kind of about it.
I think so.
Should we sum it up?
I think my chart sums it up.
All right.
I didn't write any.
Cut the last part off.
All right.
Oh, you guys got questions, concerns? All right.
All right, very good. Thanks.